I'm Teresa Schumard, and I'm happy to have you all here today. The title of our webinar is Violent Moving Nightmares, REM Sleep Behavior Disorder. Could we go to slide 2, please, Sean? We have a little bit of housekeeping to talk about here. If you are listening to the webinar live today, then type your questions into the chat box at any time during the webinar, and we will go over those questions at the end. But we will also have an open mic session near the end if we have time, and I think that we should have time today. Next slide, please, Sean. At the end of the webinar, we hope to unmute all the attendees so that they may share their REM sleep behavior disorder experiences or struggles. Those speaking need only give a first name as an identifier. We are going to discuss as our learning objectives today RBD, the treatments and safety precautions, and we are touching on RBD's comorbid conditions, meaning the conditions that may accompany the disorder. Next slide, please. This is a quote from Dr. Carlos Shank, who was the first to identify REM sleep behavior disorder. He is just a pioneer in many areas, but this seems to be his shining star. Okay, we'll talk a little bit about him in a minute. Let's go to slide 5, and we'll have a few vocabulary words. And we're not going to stress on them, and remember, you can go back. You don't have to write all this down because you can go back to the webinar and listen to it again on the recorded version, and you can take notes. We'll be also publishing some of these vocabulary words in that section of our website. So a polysomnogram is just a type of sleep study that you may or may not have had. Some people have only had home sleep studies, and they are not inclusive enough with the channels, the number of channels, and what they're measuring to be able to help diagnose parasomnias, or REM behavior disorder is one. Normal sleep is divided into non-rapid eye movement and rapid eye movement sleep. And we know that stage R is REM sleep. And it's a stage that's characterized by the rapid eye movements, muscle twitches, and respiratory variability. Tonic REM is a state with no eye movements, but you can still be in REM with that. I'm going to show you some pictures later of the eyes as they are in REM. And REM increases as we go through the night, so the periods of REM will get greater and greater as you go. REM atonia is a phenomenon of sleep paralysis. The brain shuts off stimulation to the large muscle groups during REM, immobilizing people so they don't act out their dreams. Total muscle atonia is what we call this, and it is the muscle tone. It's actually Mother Nature's way of helping us not to act out our dreams. The muscles are paralyzed during REM via Mother Nature. So, slide 6, please. Idiopathic is anything relating to any disease or condition that spontaneously arises for which the cause is unknown. REM behavior disorder, which we're going to call RBD from this point forward. Parasomnia with repeated events of dream enactment. Those with idiopathic RBD often later develop other neurological features, Parkinsonism, and a host of other cognitive impairment disorders. So this diagnosis of RBD can allow for early intervention of those neurological disorders. So there's I know if you suffer from the disorder, you're probably not thinking of it in terms of good news, but that is some good news. RBD has a special link to Lewy body dementia and Parkinson's disease, as RBD may be an early warning sign. Nevertheless, not all people develop both diseases together. So keep an eye on it. Stay close with your doctor, and make sure that your family doctor or your internist knows about your diagnosis of RBD. Your doctor can use the results of the tests that you are given to see whether you have a muscular problem or a nerve problem. So the EMG, the electromyogram, is the part of the study of a sleep study, a PSG, where the electrodes are placed on the muscles in places like your chin, legs, arms. So, we're going to talk about that in a minute here, and how those placements have a special part of that whole diagnosis. If you look up in the figure there, you can see the Lewy body dementia, and Lewy LBD it's a disease that's associated with abnormal deposits of proteins, and those deposits are called Lewy bodies, named for Friedrich Lewy, a German neurologist that discovered these deposits. And the deposits do disrupt the brain's normal functioning, and that was he saw this in 1912, and it was the very beginning part of Parkinson's disease, and so the proteins were named Lewy after him. And thank you to Drexel University for this great image of the proteins. Slide 7, please. This is not a live video that we have here for you, but I encourage you to go to YouTube at some point and just type in RBD, American Neurology Association, or ANA, because this talk is just, next slide, I'm sorry, Sean. Sorry, guys. This is Dr. Abadan, and this lecture was given at the American Neurology Association in 2016. And this is actually not the bed partner, but the actual patient. While, women can suffer from RBD, it's usually men in the later part of life that develop this. But there are circumstances where you'll see middle-aged men and women that have the disorder. And there's a link with RBD between dream content and the motor behaviors in REM, sleep behavior disorder, RBD. It's very common that dream content will include fighting off animals or unknown people, which may explain some of the violent behaviors that people experience. As far as emotions, fear and anger are most common during dreams, and the aggressive behaviors are prevalent because of that, and it contrasts with the typically mild-mannered temperament of patients while they're awake. During wakefulness, they're totally different people, and you will hear bed partners and spouses and family members say, he or she is just not this way, in real time, wake time. RBD during normal REM sleep, remember that we experience a state of muscle paralysis, which does not allow us to act out our dreams physically. When you're looking at RBD, and the people that suffer from it are physically, acting out the content of their dreams. They're often kicking, screaming, punching, jabbing, jumping out of bed, injuring themselves or others when faced with dreams that are action-filled or unpleasant. When they wake up with the RBD, it's usually a quickly alert person that they present, and they can recall the content of their dreams, but they may not be aware that they were moving. Now this is, I hope that at the end that we hear from some of the people here today that suffer from this disorder, because you can really, or the bed partners, we encourage that, because you're going to be able to help other people and share, your experiences, and you do not have to say your name, just maybe a first name, just so we can identify you if we need to get back to you or something like that. We'll know which contact information, and feel free to put your contact information in or write to us, and at the end we will show you that address. All right, slide 8, please. These are Doctors Shank and Mahowald, who discovered, Dr. Shank especially, was involved and lead investigator in this project, whereby they discovered REM sleep in a patient that was having a sleep study at Hennepin County Medical Center in Minneapolis. And my dear friend, Andrea Patterson, who is no longer with us, was a sleep technician at the lab there, and she told me about the study and how it just was amazing to them, because they said, well, he cannot be doing this. We're watching him. He's in REM sleep. How can he be doing this? And so, Sean, you can replay that if you want, so people can look at it again. I'm having a hard time with getting it to click. It was very much known, and at that time you have to remember or understand that sleep medicine was in its infancy, and so this especially was a big discovery, and they called it the Minneapolis disease, the Minnesota disease, because that's where all the cases were being discovered and found? Well, everybody was going there to have their sleep studied as soon as they heard about this. So it became the Minnesota disease, but that wasn't true, and it became later on rapidly known throughout the United States. Rapid eye movement sleep behavior disorder was first reported by Shank and his colleagues, like I said, in 1986, and it was incorporated as a parasomnia in the International Classification of Sleep Disorders First Edition, what we call the ICSD number 1. There have been 3 of these classifications, 4, no. Anyway, there is just a wealth of knowledge that continues on with research, and so it has to be updated. There are well over 100 sleep disorders, if you can believe that there are that many. But if you would look at this ICSD, you would be able to see all of them. And I'm going to show you the classifications in just a little bit. Slide 9, please. We were talking about the limbs earlier, and if you had a sleep study that incorporated all the channels, I want you to just do something right now as you're sitting. Put your foot flat onto the floor and put your fingers where the diagram shows on your leg. And now flex your ankle up and down, up and down. Can you feel that muscle in there moving? Well, those little bursts that you see denote limb movements in the person that's being studied on the PSG, on the polysomnogram. The same with the arms. You can put electrodes on the arms, and especially with Abadan. Now, in the normal sleep study, you're not going to always have the arms. Like if you're trying to diagnose sleep apnea, for instance, you would not have the sensors on the arms, but most usually the legs are included because we like to look for everything possible that could be hidden, like restless leg syndrome will show. Slide 10, please. What you're seeing here, don't be overwhelmed by this, but if you look at, Sean, can you put the cursor over the eye channels and just kind of show that would be right above the green. Yeah, there you go. Right above the green area in the top section of A, you can see that the eyes are, that what you're seeing, it's sort of like apart and then comes together and comes together. That's the eye movement that goes on during REM. Have you ever watched someone sleeping and you know, if you notice while they're dreaming, their eyes look like they're twitching behind the lids? So very, very, I mean, this is what sleep techs wait for. This is like the cream of the crop of the night, because you wait for REM because, well, you first of all, you know your patient is getting some good restorative sleep, but, you know, in the case of RBD, this is not a very welcome sight. But if you're trying to diagnose, it's imperative. Now, if you look at the section B, oh, I'm sorry, look at the chin. Can you see that in the green area up top there in A? Pretty much the chin, which is another muscle that we measure in PSG, is fairly quiet until you get to, you know, the second half, and it starts to increase. But the bottom one, you can see that things are going on. I mean, not just in the chin channel at the green stripe, but in all the channels, because that denotes that they're moving. But their eyes are still doing that REM characteristic. Okay. Next slide. 11. These are the categories of sleep disorders: the insomnias, the hypersomnias, sleep breathing disorder, which includes obstructive sleep apnea, infant or child sleep apnea. Very important to have the children studied if there's any, suspect of, sleep apnea, the snoring, the sound of their voice sometimes will give it away. We're going to be talking about infant and child sleep apnea quite a lot in the next few months. You have a whole generation of people that you can save from suffering later in life. Circadian rhythm, sleep-wake disorders. That's jet lag, non-24. You've seen that on TV, I'm sure. Shift work, delayed sleep-wake phase. That's the teenagers, they don't want to go to bed sometimes. Well, they have, a certain amount of this. That's just their makeup. It's how they were built. And when they get older, then, they sleep earlier. The parasomnias, of course, the big one being RBD. There are other sleep movement disorders, not to be confused with the parasomnias, because these can be disorders of the legs, gritting of teeth, that sort of thing. The PLMS and restless legs. PLMS, periodic limb movement, and restless legs, is not a wild thrashing like you see with RBD. It's mostly a feeling that the person experiences, sometimes not letting them go to sleep, because they feel, the one way to describe it is patients will say, I feel like there are bugs crawling all over my legs. So let's go to the next slide and talk about the parasomnias. They are, a group of sleep disorders that essentially involve unwanted events or experiences that occur while you're sometimes falling asleep, sleeping, or waking up. Not that would be the RBD, but there are others that we'll discuss. Parasomnias can include abnormal movements, behaviors, emotions, perceptions, or dream enactment. Although the behaviors may be complex and sometimes appear purposeful to others, like the bed partner, the patient remains quiet and asleep during the event and have no memory that it occurred. Anyway, we can figure that the daytime is especially hard sometimes for people that suffer from RBD, especially because, number one, the medications that they're having to take, and number two, they were disrupted. You can have a lot of strained relationships with bed partners. Sometimes separate beds have to be employed because, it's just unsafe sometimes, until other, interventions come into play, at least for safety. So it can strain relationships, and, imagine, if you're being hit, you're not feeling very happy about that. And of course, the person that's doing it is not feeling too great either. maybe, would feel like they would want to stay away from their loved one just because they're afraid they'll hurt them. So all kinds of things can come into play. We'll talk about that hopefully at the end of this webinar so we can discuss it further. So you can have confusional arousals, sleepwalking, sleep terrors. All these things may come into play. Sleep eating disorder, another parasomnia, on and on. We're trying to keep this short today, so I'm not going to go deeply into those. Sleep talking also is a good one to look up if you suspect you have that. Let's go to slide 13, please, Sean. This is the ICSD-3 table, and it comes from the International Classification of Sleep Disorders, 3rd edition, by the American Academy of Sleep Medicine, and it was updated in 2014, so this is very recent. The confusional arousals you'll note there. And then the REM-related, those are non-REM-related parasomnias, but the REM-related parasomnias, RBD, and recurrent isolated sleep paralysis, which is a whole webinar in and of itself. And nightmare disorder can just haunt people. Next slide, please. Clonazepam or klonopin is a benzodiazepine, sometimes called benzo for short. So let's define benzos first. They're called minor tranquilizers. And these drugs are often prescribed by a doctor to help people with anxiety or, sleep problems, getting to sleep. There are about 30 different types with, generic names included of benzodiazepines. Different types of benzos work in the bodies for different lengths of time. But klonopin has been, or clonazepam, has been the traditional treatment of choice by prescribing physicians because it curtails or eliminates the disorder in about 90% of the time, which is pretty decent. The advantage of the medication is that people don't usually develop a tolerance for the drug, or even over a period of years. So, and it helps to reduce the violent behavior. When it doesn't work, klonopin, sometimes antidepressants, some antidepressants, or melatonin may reduce the violent behavior. I've noticed a lot of people that I talk to use melatonin successfully, some not so successful. It's a dietary supplement which may help reduce or eliminate your symptoms. It's very well tolerated and has few side effects. But before I go on to the next slide, it should be noted that klonopin may cause side effects such as daytime sleepiness, decreased balance, and worsening of sleep apnea. So if someone is using CPAP before the diagnosis of RBD, they should contact their physician, their sleep physician especially, in case that their machine's pressure needs to be adjusted. Because this could be two different physicians. And just on the safe side, I would bring that up. Be your own advocate there. Doctors often recommend changes to a patient's sleeping environment when they have RBD. for safety reasons. They may have padding on the floor near the bed, remove dangerous objects from the room. Maybe there's barriers on the sides of the bed and furniture clutter is cleared away. People with RBD may want to protect their bedroom windows, possibly sleep, of course, in separate bedroom or away from their bed partner until the symptoms are controlled. Slide 15 just gives some pictures of common scenes in RBD. It's much easier to tell in video, of course, but we really still are learning, and research is still going on today. Genome testing is and research is going on for RBD as we speak. I just saw it yesterday that it was being conducted. It's not even a paper yet. Okay, I would like to ask Dr. Carl Stepnowski, our Chief Science Officer at the American Sleep Apnea Association, to come online. Sean, can you unmute him, or has he been able to get in? Was he able to get in? Sean? For the next slide with the studies on it. Sean?
This is Carl. Can you hear me?
I can. Welcome.
Oh, great.
Can you tell us
Thanks.
a little bit about these two studies that ASAE has going on?
Sure. Yep, be happy to. Just want to point out the American Sleep Apnea Association is a patient-led, patient-governed organization. So the two really unique aspects of these studies, even though they are on different topics, is that they're both really driven by patient participation and patient input onto the research studies themselves. The first one is called the Overlap Study, and the ASAE is doing this study in conjunction with the COPD Foundation, and it's funded through the Patient-Centered Outcomes Research Institute. And it's been a neat study because we first did focus groups to learn more about the challenges that patients who have both sleep apnea and COPD, and together they're called the overlap syndrome, which is why we named this study the Overlap Study. And that helped inform a larger clinical trial where we're trying to learn more about providing information and support to folks both online and through peer coaches and with some respiratory therapist help on improving adherence with CPAP. And for those who are using oxygen therapy, also improving adherence with oxygen therapy. So if anyone on the call has both disorders and uses CPAP, you can read more about it here, or if you might know of anyone who might have both and uses CPAP, you can pass this information along to them. That'd be much appreciated. And our second study is called the Sleep Health Mobile App Study, and that's an iPhone-based study where you can go to the Apple App Store and actually download it as its own app, and it's a research study that we can deploy on the phone. And what we're interested in learning more about is how nighttime functioning or nighttime sleep and sleep quality affects daytime functioning next day. So you can learn more about that with the links that are provided.
Now, in that first study, Dr. Carl, there's no medication except for the oxygen, correct?
Right. Yep. No medication. It's real, and a lot of studies are on people who are newly diagnosed, and then the study provides a therapy or tests a new therapy. In this case, we're taking people who are already diagnosed and who are already prescribed CPAP therapy and possibly oxygen therapy. So it's just looking at providing education and information to them, so it's not medication-based.
What I really like about that study and the other study is that you do not have to go anywhere. You don't have to travel to a hospital or a lab somewhere. You can do this, remotely. Awesome.
Right. That's the neat feature of both studies, is that a lot of times with research studies, you have to go in person to a clinic or a research lab. But both of these are designed to be national in scope and provide information about the study online and get answers questioned by phone calls with research study staff, and then really either do stuff online or on the phone. It's a new way of doing research.
Well, let's open up. Let's see if we have any questions. Sean, you can put it on the last slide if you like. That way they'll have the information. We really would love to hear from people that have RBD or have a loved one with RBD. Don't be afraid to just speak up. We can hear you.
Mm-hmm. Hi, Teresa. This is Adam.
Hi,
Adam. That was a wonderful presentation. Thank you for taking a deeper dive into a world I thought I knew a little bit about, but obviously that was much more in depth than even I knew it as a layman in this world. I posted in the chat room that I can remember waking up as a 5 or 6 year old child, sleeping between my parents in their bed and watching my dad punch the pillow. To only years later have my mother tell me that on a few of those nights he connected with her. And it was a scary sight, but the reason I tell this story and share it is not because I'm proud of it, but as a warning, because this kind of behavior, as we know, leads directly to a neurological disorder like Parkinson's or Lewy body. And my father, unfortunately, was diagnosed with early onset Alzheimer's at 50, which we now know in hindsight was Lewy body Parkinson's. As a result of having untreated REM, sleep behavior disorder, his entire life, going back to his childhood, he was a sleepwalker as well. So it's important that as much as people don't like to talk about the stigma of this, that they understand it's a direct warning sign for other issues, and that if you start to treat this now, you can avoid those other long-term comorbidity, Parkinson, neurological dementia type diseases. So thank you for doing a webinar on this subject. It's close to my heart.
Oh, you're welcome, Adam. Does anybody else have something they would like to share?
Hi, this is Judy. I'm 57.
Hi.
I'm a
Welcome.
50-year-old female. Thank you. I have a question in that several years ago, I began kicking in my sleep. Now, I've never done anything with my arms and was curious and I've never been diagnosed with RBD, but I've suspected it, and was curious if it's always one limb or all your limbs that are moving. Anyway, that's just out of curiosity, trying to figure out if this maybe pertains to me.
Have there been any violent behaviors, like where you were told that you were, kicking at something or sitting up and thrashing about?
My husband and I fondly refer to this as kicking dwarves because the first time it occurred, I woke up and I said, I know exactly what was happening. I was fighting off these dwarves or something. And I always remember what I'm dreaming, and it always involves fighting something, kicking to get it away from me. So those are the only behaviors that I've not done the sitting up. One time I did throw myself out of bed. but and then I started using a CPAP machine, and I would say the incidence of this have decreased, but still occur periodically.
Well, during the time that you're having an apneic event and not breathing, you will sometimes do those kinds of leg movements just because it's a fight or flight type response, just as RBD presents. You are having a period where you're not breathing while the brain says you have to breathe or you're going to die, and so you have what we call a recovery breath. And as I watched people do this time and time and time again, you could totally see that they were, just having that response. The body was breathing again, and it's a very dramatic looking. When you watch someone that has sleep apnea, totally dramatic, because it does look like they're fighting. But if there haven't been violent, actions. I mean, we can always, sometimes we remember our dream after the fact. You know what I mean? Like you could be out of REM by then, but you're still remembering it. So it seems like, oh, I was just dreaming that. Well, you could have been just dreaming it 2 minutes ago, but now you're in another stage, probably awake, or have what we call arousals of sleep. Carl, would you like to add anything to that?
Yeah, I was gonna say the first thought was, depending on the kinds of limb movements there is, and Teresa makes me think we should do a webinar on PLMs and restless legs. There's something at night that happens that's called periodic limb movements during sleep, and then if someone has similar kinds of movements during the daytime, it can be something that's called restless leg syndrome. But for people who experience mostly the limb movements during sleep, there is a high association of those movements with sleep apnea. So that's great that you've already been diagnosed and prescribed CPAP.
The movements that I'm referring to are very rapid kicking movements.
Right.
Usually kicking my husband and waking him up. So you think that that's more of a sleep apnea condition, and less?
Sometimes.
Okay.
Sometimes
it can be. I would ask to be studied with your CPAP on.
Yeah. Yeah, because what most physicians would do, and we definitely recommend talking to your physician. When people are first being evaluated for possible sleep apnea and PLMs, instead of treating the PLM separately, for quite a few people, the limb movements will go away with sleep apnea treatment. If it tends to persist, if the limb movements tend to persist, then let your physician know, and that's something that they can potentially try to treat separately. But there's a lot of overlap. Once you're on CPAP, though, what matters is whether or not the CPAP's at the right pressure and how much you're using it, and because for the most part, when CPAP is at the right pressure and you have very little mask leak and you're using it for whenever you're asleep, if you're still having events, limb movements, then it probably is something separate. So it's just a matter of talking with your physician and disentangling those issues.
Right.
Does that make sense? Yeah.
Yes, it does. I use a automatic titrating machine, which is kind of the route I guess insurance companies are pushing for now, because they don't want to cover the titration studies.
Right. And APAPs are great, and for the most part, they do a really good job. It's just talk with either your DME or physician, get a data download, and just make sure that the minimum pressure is high enough. It's a lot of times when they prescribe APAPs, they set the minimum pressure to 4, the maximum to 20, and they say let the algorithm do its job. And that's great in the beginning, but if are you someone who's used to the pressure now?
Yes.
Yeah, then you can work with the physician talking about maybe moving up the minimum pressure, because the basic idea is sometimes you're undertreated and you could have some hypopneas or small apneas if the pressure is too low while the algorithm starts to move up. So with the data download, the physician can take a look and say, yeah, it looks like you're having a few events if we just move the minimum pressure from 4 to 6 or from 4 to 8. This way when you put the mask on, you're ready to start at a 6 or an 8, for example.
I see.
That's one way to kind of fine-tune the APAP so that it works, the best for you.
Thank you. That's very informative. And I'm sorry, I don't mean to get off track with this, but I just wondered what the connection was and what the differences really were between the RBD and the other conditions that you presented.
Well, it can be confusing. Right. It can be confusing, and if you have questions, this is the best thing you can do is reach out and learn, what you can. Be proactive what you're doing.
Right, absolutely.
I'd
like to make two more.
People that suffer from RBD, does this occur every night when they sleep or occasionally?
It's not every night. And it depends, the frequency depends on the person. Depends on their condition. Sean, could you put it at the next slide, please, with the...
Hey, I'd like to just jump in with one more point on apnea and CPAP and periodic limb movements. And that is it just depends on how CPAP's used. A lot of people will use it for, let's say, half the night, 3/4 of the night. And one thing that is sometimes discussed with patients, but oftentimes not, is what's called REM-associated sleep apnea. And when we have REM sleep, the muscles have less tone, including the throat muscles, so we're more prone to having apneas and hypopneas during REM sleep. Well, guess when REM sleep primarily happens in the early morning hours, those last 1 to 2 hours of sleep, when we're most likely to have taken the CPAP off. So, if you are not, possibly not using CPAP the entire night and you do have REM-related apneas and hypopneas, that's when you could possibly experience some of those extra limb movements too.
Thank you.
Sure.
Anybody else have something they would like to share or question? Just a show of hands in the section where it allows you to type your questions in. Just a show of hands, how many people have experienced RBD here today? And we'll look at that later, or we can look at it now. Well, if anybody else has anything to share, this would be the time. And Adam, are you still here?
Figuratively.
I was wondering, since a lot of people are not familiar with ASAE, if you could tell us a little bit, and expand on what Carl said about it being patient-led and how that differs from other organizations involving sleep.
Well, as a precursor, people used to ask me as a patient advocate, and I used to say I'm not a doctor. I just play one on TV. It's both a liberating, but also can be a very dangerous sort of tightrope to walk for us as an association, and for me individually, in that, in the traditional world, the patriarchal, matriarchal figurehead in the healthcare field, it was a one-direction conversation. And for most of our cohorts, most of the people in our apnea population, undiagnosed, untreated, let alone treated well, or treated poorly or partially treated, they've been missed by the system. So the traditional healthcare system has quite honestly failed them in some aspects, because usually it goes 7 to 10 to 15 years before a patient's diagnosed. So there really hasn't been a patient advocacy association or patient voice, because most of our patients never make it out to the other end. With the advent of CPAP and the advent of dialing in the titration and getting the right treatment for the individualized person, it's now enabled another generation of long-term PAP users to start to connect the dots and put the pieces together. And we sort of had to have done that as we were originally founded by doctors, and we're now run only by patients. And we have doctors on our board, but they are patients first. We have the existing doctors were moved into more of a medical health advisory role. And what we found is, unlike an airplane where we get on a plane and we fly in the back and we hope and pray that the pilot is doing their job, we want to be informed. We want to be in the cockpit. We want to know where the flight's going, where our treatment path is going, what are the options, and how I best want to get myself and then those around me to a safe outcome. So as the stewardess says on an airplane, put your mask on first before you help others around you. In my case, that's what I did for myself. I then did it for my then, at the time, 2-year-old daughter, who's now 10 years old and thriving. And then once I was able to help her, we were able to really start to look at this Patient Advocacy Association as an outlet to start to help other people. And that's sort of our evolution from sleepapnea.org, which is the American Sleep Apnea Association, into the more preventative public health aspect of sleep health and early diagnosis and recognition and multiple interdisciplinary interventions for treating sleep disorder breathing all along the way from cradle to grave. And with that, we've, as an organization, we've also evolved and learned that, I used to look at myself just as a sleep apnea patient advocate, but now it's more about, is sleep a part of the cardiovascular world? Is it part of the diabetes world? Is it part of the medical world, the mental health world? If sleep is not being considered in whatever the specialty is or whatever the question is, then we don't have the whole story. Because we sleep a third of our lives, and we sleep for a reason, and we know we feel better when we sleep well. And helping people get good quality sleep is the long-term mission of the ASAE, quite honestly. I know I went on and rambled a bit, but was that helpful? Or
Absolutely. I think it's a great opportunity to let people know what the ASAE does. If this is maybe the first time people are connecting. I know some of our friends from the International Association for the Study of Dreams are here today. I saw them on registration. Welcome. I've connected with a lot of people in the RBD community over the last week or so, and we just really welcome you to join us. And we have an Awake. It's called Awake Sleep Health. You can look us up on Facebook, or go to our main sleep apnea Well, it's in a Facebook.
That's a good segue, Teresa, because Awake was an old existing sleep apnea patient support group, primarily run out of DMEs and clinics and hospital settings. And it really just didn't occur to us until we really became patient-run that we've been sitting on Awake, which the acronym is Alert, Well, and Keeping Energetic, which relates to what everybody has to deal with during the day, not just whether you're a sleep apnea patient. We have an entire society walking around as zombies, that are glued to our Starbucks coffee mugs or any other brand coffee. And we really want, we know people can't necessarily get to an in-person Awake meeting. We really wanted to build our communities online and be a community of communities for other comorbid people who have a sleep component to their issue. And you know, we invite you to come and join the Awake Facebook group. But also, even in the month of September, we celebrate Sleeptember, which is the month of making sleep a priority and discussing how it overlaps with you at home, in the workplace. It's back to school time. It's back to work time. There's a whole bunch of things. So, you know, we invite you to come and look at our web pages, our different channels as far as Facebook and Instagram and Twitter and Facebook and our Sleep Health Forum for however you feel comfortable to ask us questions or learn more. And we're constantly iterating and evolving, and we've come a long way, and we have a long way to go. I would guess would be my final message for you as far as where we're at with the ASAE right now.
I have a question for you.
Yes.
How can the average person like myself be involved and help others? Do I go to the ASAE at sleepapnea.org site? What can I do?
You can definitely email and join our newsletter at ASAE@sleepapnea.org. We have our CPAP assistance program, so we have discontinued and outdated CPAP and AutoPAP machines and BiPAP machines for a $100 program fee that we're getting to patients. But more importantly, we're also looking to get people's used machines or people's machines that are being used as doorstops, or if someone's loved one is passed on, and make sure we get them in the hands, because they don't do any good sitting on shelves, and we want to make sure we get treatment to as many people. We're looking to start awake groups in areas where they're not there, so we're always looking for leaders in that regard. I invite you to download the Sleep Health app study on the Apple iStore if you have an Apple phone. We will have the Android version out soon. We have fundraising campaigns and classy campaigns either through our ASA Facebook page. We invite you to come and participate and, you know, generate research questions. We're looking to bring people through our sort of our programs and identify the proper spots for them to work with us and to grow with us, because we're only as, you know, we can only go as far as we are here. So these webinars are a start, and so we're not getting big major attendance, but they're eventually, people are downloading these and watching them later. And the more we do them, the better we'll get at them, and the more we can help our cohort and our community and our caregivers. Does that help?
Yes, it does. I wanted to add the point that when I was trying to get diagnosed with sleep apnea, the process that I had to go through was extremely difficult, and I assume there are probably other people out there having the same issues, where it was very difficult just trying to get the testing done and getting insurance to cooperate with all those things so that I could even obtain a CPAP machine. So that's...
Yeah, it's admirable, and we applaud you for coming this far, and the amount of obstacles and barriers that we have to all overcome to get to this point is why we're doing the job. I don't want to say we have all the answers, but there's definitely a more streamlined, more efficient way to make this journey a much better path for the people that follow us. And just like you're here today on a phone, you know, asking good questions about what periodic limb movement or this, you know, REM behavior disorder, you get to learn the difference. And, you know, you couldn't have these conversations before, because now you're dialing in on the single variables that are affecting your sleep at night. And that's because you're getting better sleep at night. So you keep improving as you go. And you fine tune it like a car mechanic, because that's, at the end of the day, that's what we all are.
How long have you had your diagnosis? When were you diagnosed with sleep apnea?
A little over a year ago, but I know I've had it for probably at least 15 years before that time. But trying to get the testing done, the problem was, you know, the insurance company doesn't come right out and tell you what you need to do. They would just keep denying any testing to be done, and what they wanted was the home testing to be done. So maybe a lot of people don't know that. I don't know. I finally figured a lot of this out by researching on my own, had the home testing done. Then I didn't really know how to get the machine. It was jumping through hoops. Basically, I had to even educate my doctor about what they wanted done. They wanted the automatic titrating machine. They didn't want me to go back and have, any testing done to determine settings. So it was all about eliminating the testing and the cost of testing.
So you did go to the sleep lab, or what happened there?
No, never. Had a home test done to determine that I had severe obstructive apnea. Had to go back to my doctor, had to have him request an automatic titrating or a CPAP machine. And that's how I finally got it. Yeah, insurance would not cover any kind of testing, any kind of titration testing, or even the diagnostic testing to determine if I had sleep apnea. That had to be done at home.
This is why it's so important for patients to be involved.
Yeah, I was going to say, what kind of doctor's door did you walk through? Was it a primary care doctor, or are you in a healthcare system, or?
Yes, it was my primary care doc, but I just think it's getting different. I mean, I've talked to some other doctors who were kind of unfamiliar with what they're not paying for now for patients, or what insurance won't approve, and it's definitely deterring people from getting diagnosed and getting help. And
yeah, it's I don't mean to cut you off, but it's a very complicated, convoluted story right now. They want you to do home sleep study tests first for the everyday patients, and then the complicated patients will then go into a lab. But there's a whole lot of, as you just identified, a whole lot of different people that it's not just insurance. There's a lot of different stakeholders that have gotten their way, and what's best. At the end of the day, without me going down rabbit holes, I can tell you that your best interest as a patient was not first choice or first priority.
No, as a matter of fact, it was very interesting because the night that I did my home testing, I had one of the kicking episodes that, had I been in a lab setting, it would have, they would have had record of that, but didn't, because they wouldn't cover that kind of testing. So
what part of the country are you located in?
I'm in Ohio.
It's so important for patients to be involved. They're going to be, everything is changing insurance-wise now, but there'll be a time when it stabilizes, and wherever the cards fall, it may take, an army at the grassroots of patients.
Yes, I think it's important for people to support other people, because it's easy to give up trying to jump through the hoops you need to get the help you need. And a lot of doctors, I think, are a bit confused about the process as well and what to do.
Oh, yeah. The whole system is sleep deprived in itself. Are you looking at any of the data on your machine? I know Carl had asked you that earlier.
I was, and I kind of quit doing it. It wasn't as good as it should be, but it was close.
And when you say you were looking at it, you were looking at the summary data that's on the LCD screen on the front of your machine, or you were actually downloading the data from the card, or looking at
looking at it through an app.
Through the app for the manufacturer. So you're looking at their summary data.
I think, yeah. It's Bluetooth, and I was looking at the information, yeah. I kind of quit looking at it because I thought it was effective. I would get too wigged out by, oh my gosh, there was a bad day. Oh, there was a good one. There, that kind of thing.
It would be helpful to take the raw memory card out of your machine and share it with a sleep physician, because they could probably help you dial in what that auto PAP might be missing as far as your range. really find out where you're at spending 95% of your time, so that we rule out any hypopneas and things like that might be leading to those leg movements that you're having, whether they're kicking or thrashing or just happening during REM. Mm-hmm. So there's the good news is that you've got plenty of room for improvement, and there is a path for you, but it's finding the right person for you in your area. If you contact us offline, we'll be happy to put you in touch with someone in the area that would be able to help you.
Okay, great. Thank you.
So, thank you.
Well, we've gone over just a little bit, but it's been great talking and sharing. We may not have, at the end, had anyone to share their RBD experience, but I can understand that it may not be something that you are comfortable talking about, and that's okay. We're just glad that you were here, and thank you for attending. Please take note that on future webinars, you can be added to our mailing list by emailing ASAE@sleepapnea.org. You can sign up for the newsletter. Everything is promoted through the newsletter that's going on with us. It's a monthly newsletter. We don't bother you all the time, like 10 times a day or something like that. We're very mindful of people's email boxes. And you, remember, can watch the recorded version of any of ASAE's webinars by typing webinar series into the search field at www.sleepapnea.org. Thank you to all that participated today, and a special thank you to Sean Deering, who is our research assistant, who is assisting with helping the slides pass from the one to the next. And we will be seeing you next time here at the ASAE webinar series. Thank you. Bye-bye.